Hi, everyone. I'm going to let everybody take a couple seconds to join our webinar here. And while you'll do that, I'll ask you to click on the chat tool in your Zoom toolbar and let us know where you're tuning in from today. My name's Troy, and I'm the Director of Operations for Nurses Specialized in Wound Ostomy and Continence Canada, and I'm tuning in from Ottawa, Ontario. And I'm joined by some amazing, what might be some friendly faces for quite a few of you who might have been on some of our past webinars. Today's webinar is going to be on strategic pathway for infection management and biofilm defense. And I'm joined today by a great panel here. We have our expert presenter, Dr. Kevin Wu, who will introduce in a second. And I'll also be joined by Subven Saket and Carolyn Brochu from Smith+Nephew. Before I introduce everybody, I'll remind you that this is being recorded today. So if you don't have a chance to, if you have to leave early or if one of your colleagues want to come and watch this afterwards, we will have it available on demand on our NSWOC website. Anyone who's in attendance today will also be receiving a certificate of attendance. Just give us up to about 2 days just in case for us to get into your email inbox. And lastly, we're going to have a Q&A session at the end of this webinar. So if you have any questions for the panel, please post it in the Q&A toolbar, tool in your toolbar, and we'll make sure to get to that at the very end. We will also be having a survey towards the end of the webinar as well, so do keep an eye out for that. So without further ado, I'm happy to introduce firstly our expert speaker, Dr. Kevin Wu. Kevin is an associate professor at Queen's University School of Nursing and School of Rehabilitation Therapy in Kingston. He's also known as a leading Canadian nurse researcher in the areas of wound ostomy and continence issues, and has served on a number of expert panels and advisory boards to develop best practice recommendations. And for over 20 years, Dr. Wu has sustained a prolific research career focusing on topics such as chronic disease management, knowledge translation, and patient safety. And he's authored over 130 peer-reviewed journal articles and 19 book chapters. So by blending his research with an active clinical practice, he has an immediate and profound impact on the health of people living in Canada. Kevin is also the web editor for the Advances in Skin and Wound Care website and the research and practice co-chair for NSWOC, for our organization here. He's also a past regional director for North America and a research chair for the International Skin Tear Advisory Panel. So before we get to Kevin, I think we're going to first invite Sub to our medical education manager with Smith+Nephew to take us through a couple poll questions. Thank you, Sub.
Great. Thank you, Troy. Sorry about that. So first off, I'm very excited to be here to join you in for this evening. I wanted to launch the first 4 polling questions. After the first 4 polling questions, we will also have a question at the very end of the webinar, just to assess the impact of this particular education forum. So the first polling question is, where are you joining us from today? I know some of you guys popped it in the chat, but give us a view as to where you are coming from. And we'll close the poll in a few seconds here, whenever you're ready, Troy.
Perfect. You should be able to see it there now.
Perfect. So the majority of folks are joining us from Ontario. That's wonderful. Let's move over to the next polling question, please. So currently, how confident are you in managing when to... Sorry, my screen has the poll on it here. Currently, how confident are you in knowing when to aggressively treat biofilm versus managing infection?
Awesome. And I'll leave it open for a couple seconds till maybe we get at least over 50% there.
Perfect. We've got the options: A, not confident at all; B, somewhat confident; D or C, fairly confident; and then E, completely confident.
Awesome. You should see the results on your screen there.
Excellent. So we've got the majority of people fairly confident and somewhat confident, and a few people at 20% not confident at all, 3% at completely confident. Okay, the next question is, do you follow a standardized pathway or protocol for diagnosing local infection and wounds? A, yes; B, no.
Alrighty, and you should be able to see the results in front of you there now as well.
Perfect. So we've got about 67% of people who said yes, they do follow a standardized process. So that's great news. And the next polling question is, I can identify the difference between local infection and biofilm and diagnose accordingly. A, no, B, sometimes, most of the time, or all of the time.
Perfect. And I'll share those results with you again.
Perfect. We've got about 47% of people who have said most of the time, 38% of people that say sometimes. Perfect. So with that, I'm actually going to turn it over to Kevin, who can begin the presentation. So thank you, Kevin.
Excellent. Thank you, Sup, and thank you so much for Smith+Nephew to sponsor and support this event. And lovely to see so many of you. I'm just looking at the number of participants, 150 people. That's wonderful to see so many people joining us this evening. And I got a sense in terms of who's in the audience. Lots of people from Ontario, yay. And I think there's some interesting phenomenon about how we're following pathway and protocol around diagnosing wound infection. So this evening, I'm going to spend a little more time to talk about a pathway that we've developed. So this is my disclosure slide, and in terms of what I'll be presenting and the detail. So the learning objective for this evening, I'm hoping by the end of this event, we have a chance to review infection management pathway and the evidence with the use of cadexomer iodine dressing to treat biofilm and biofilm-related infection problem. And we'll spend a little more time to talk about difference, particularly around local and spreading deep infection, and how we can utilize a biofilm-based wound care protocol to address local infection management. And I'll highlight, if you have not heard about this paradigm, this approach already, is called a step up, step down, to really emphasize the importance of being more aggressive at the beginning to manage chronic wounds with the hope that we can reduce chronicity, we can promote better wound healing. And then, of course, we want to empower all of you to use this infection management pathway. We welcome any feedback from the presentation, and hopefully you will be able to see a copy of the pathway and see whether there's a utility in your clinical practice. Just want to sort of give you an impression about burden of chronic wounds. I think we're all working in clinics and hospital. We got this sort of a skewed view of patients who have wounds. In fact, when you look at globally, the prevalence of chronic wounds is about 2.2 per 1,000 population, and translated into almost about 40+ million people who's going to develop new chronic wounds each year. So that number is actually quite astounding, isn't it, in terms of the enormity and the complexity of wound management. And in fact, about 30% of all those wounds are very difficult to heal, hard to heal, and sometimes it can be more than a year in terms of the duration, perhaps because of patient adherence issue, system issue. And I think what we're trying to do is to understand some of the local wound care issues that we as clinicians can address and be more consistent with the approach to chronic wound management. I think that's a good segue to really lead to my discussion about biofilm. When you look at the literature, they talk about, well, more or less about 80% of chronic wounds have biofilm. Most experts will agree that almost 100% of our chronic wounds that we manage would have biofilm problems. And that's why chronic wounds is really a chronic biofilm issue. So this is the step down, step up, step down clinical method. Whatever way you want to look at it. The important part is we start with multiple therapies being as aggressive as possible with our wound management. Now, as you can see on the slide, that may include very aggressive shock debridement to remove all the non-viable tissue. And we'll come back to talk more about some of the maintenance and ongoing debridement needs. And that's the best way to disrupt the biofilm, followed by topical antiseptics and systemic antibiotics where needed. And last but not least, important about thinking of the supportive therapies that may include offloading, nutritional support, diabetes. And over time, we can de-escalate our intervention as the wound continues to improve. And then from time to time, we might have to step up again in order to enhance wound healing or reintroduce some of the antimicrobial agents when we see the resurgence of inflammatory signs associated with wound infection. So I'm sure we're all familiar with phases of wound healing, going from the hemostatic inflammatory proliferation and epithelialization phase. Chronic wounds, as the name implies, they're chronic. And there's no really universally agreeable definition. I mean, we've been having this debate for a long time now. But in general, if the wound is not able to achieve 30 to 40% reduction in size within 30 days, that considered a wound that is not following a expected healing trajectory. We classify those as chronic wounds, not just about the duration of time, because obviously bigger wounds may take longer time to achieve, but we're looking at the surface reduction within a duration of time. So why are wounds chronic? That's the key question, right? So I think, as you can see on the slide here, one of the major factors, and we'll be focusing on this topic, is around wound infection. Bacteria in the wound, especially when we have biofilm problem, can introduce two major issues. One, it can stimulate and perpetuate this inflammatory response. Inflammation is supposed to be good, but when it's excessive, prolonged inflammation, then it can actually destroy a lot of the growth factors, granulation tissue, and all the key ingredients that are crucial to wound healing process. And second, the bacteria, when they're destroyed by your immune system, they will release toxins, endotoxins, into the surrounding tissue. And those endotoxins could be extremely damaging to the healthy granulation tissue as well. So you can see that bacteria are really, really bad in the wound environment, especially if they're in excess. And that's why we see this sort of a vicious, circulating cycle with microbial colonization leading up to biofilm problem, perpetuating this inflammatory response, and of course the outcome is tissue damage, delayed wound healing. Well, based on this discussion, we recognize there's a need to standardize the way that we identify infection and separate infection into local, covert, or biofilm infection. They're all kind of used interchangeably versus more overt, deep spreading infection that may require very different sets of tools and therapies and treatment modalities to address that type of problem. So we have an international panel. We work together, review the scientific evidence, existing clinical guidelines, consensus documents, and based on our expert experiences to summarize all the key ingredients, key recommendations on this one pager as an enabler to standardize and making sure that clinicians will be able to be consistent with the way that we review and diagnose wound infection. And in fact, this pathway has been evaluated and validated, and we're just in the process of doing a publication from some of the data that we collected from Europe and Middle East. So if you look at the pathway closely, we start with holistic wound management, we get this A, B, C, D, E. In wound care, we love acronyms, as you can imagine. I think this is very consistent with wound bed preparation. Important part is looking at the patient holistically. We need to assess the patient, the well-being in the wound, not just focusing on the wound. We have to bring in an interprofessional, multidisciplinary team, including the patient and plus or minus their caregivers to promote holistic patient assessment. We need to control the underlying cause. I think that's probably one of the most challenging element when I approach any type of chronic wound is to really understand what's the underlying problem that perpetuate, that create this chronicity in wounds. And then we can decide on appropriate treatment and evaluate from time to time. And just to give you an idea in terms of the importance of treating the underlying etiology, and people who have been to some of my presentations, I always use this case to really highlight the point about recognizing the problem that is creating this type of ulcers. We initially, when we looked at this wound, is on the calf area. We thought it was a pressure injury on this 70-year-old female, history of diabetes, obesity, also have kidney disease, on dialysis. And of course, it looked like it's a pressure injury. It's a location implies it could be pressure injury as well. And she was in bed for a long time in ICU for duration. So yeah, why not treat the patient with the pressure injury, right? So we started debriding, and we actually evacuated a huge volume of thick, smelly, tenacious, very thick fluid. And you can see in this bowl here. And as we continue to evaluate the wound, and we're actually able to identify there's quite a bit of calcified tissue on the wound bed. So now we go back to take a look. Why is this wound there? Why is this wound not healing the way that we expect it to be, despite all the measures we put in place in terms of offloading, in terms of nutritional support, in terms of looking at evaluating perfusion? So with more proper diagnosis, we actually identified this type of problem, and consistent with the patient history, that this is calciphylaxis. And basically, it's a disease condition common among individuals who have uncontrolled diabetes and also end-stage renal disease. The pathophysiology involves calcification of dermal blood vessels, causing occlusion, with poor blood supply, ischemic damage, and also with the inflammatory response, creating all those little microemboli, and further compromising circulation. And that's why people develop very, very painful lesions. And in fact, the treatment would involve hemodialysis to correct the calcium level. And there may be a need to look at anticoagulants and other medications to correct the parathyroid hormone, and also the sodium thiosulfate is often used to correct the calcium level. But anyway, we use a couple of strategies, and you can see that in addition to local wound care, we're able to improve the wound healing. Otherwise, despite the best measure you put in place with the best dressing you can find in the world, this wound is not likely to promote into complete closure. So coming back to our key topic here, once we identify the underlying etiology, a lot of chronic wounds we encounter may have infection problem. And this is the best practice guideline that I often refer to, and it's a wonderful collection of tips and evidence around wound infection management by the International Wound Infection Institute, IWII, and they refurbished this document in 2022. They define infection as an invasion of microorganisms to the wound area, evoking a host response. And depicted on this diagram here is a continuum of bacterial growth from contamination, colonization, and as the host defense and host response become more evident, then we start to see damage in the tissue, starting from the local infection on the surface of the wound to spread infection into a deeper compartment, and then eventually the bacteria can spread into the bloodstream and causing systemic problem. So what's important here is, as you can see on in this red arrow here, all infections have biofilm problem, because as the bacteria continue to proliferate, they will produce biofilm. So that really responsible for most of the chronic wound problems. And as you can see, this is on this video, we have bacteria. All wounds are contaminated. All wounds are colonized by bacteria. So as those planktonic state bacteria, they start to get together. They have ability to cell signal, like calling each other, say, "Hey, we're having a party here. Let's go for a drink." And they get together, develop this microcolony. And they produce glycocalyx material, and those are the biofilm structure that protects the bacteria from all the antibodies, antibiotics, antimicrobials. So they become more resistant to any type of interventions and ways to eliminate the bacterial infection. So the other thing I think around biofilm, as we continue to learn more about biofilm problems, is the ability for bacteria to develop tolerance. And there are different ways to conceptualize tolerance. It could be physical tolerance, and the physical structure of biofilm, the extracellular matrix, is probably a very good example how bacteria develop this tool to defend themselves against antibodies and antimicrobial agents. There's also passive tolerance, and they can produce enzymes to inactivate all the invasion of a barrage of antimicrobial agents. And the last is the physiological tolerance. And a lot of bacteria inside the biofilm, they lay dormant. So, that really a key to survive. Antibiotics, if they can get into the biofilm or get to the disrupt the biofilm, the dormanted bacteria would not be able to be recognized as the target for the antibiotics to act upon. So those become very stubborn, persistent cells in the wound environment that can regrow from time to time back into this mature biofilm. So now you can appreciate why biofilm is such a big problem for chronic wounds. I know there's a lot of pathways in this presentation, but it's really important to look at the consistent way that we follow to address biofilm problem. And this is called the biofilm-based wound management protocol. So once we identify that there is potential biofilm that is causing the delay in wound healing, the key strategies around biofilm management, there are three things that we need to think about. The vigorous, active cleansing at each dressing change, plus or minus regular debridement, depends on the availability of clinicians and experts who are able to do that, followed by the sequential use of antimicrobial dressings and topical antiseptic agents. And of course, we need to continue to think about the importance of all the, I shouldn't say peripheral, but I think the core treatment strategies to address the underlying problem. And so with the irrigation, with the continuous effort, ongoing debridement of the wound, we can actually disturb the biofilm and allow the antimicrobial dressings, topical antiseptic, to act in the more successful way. We promote this 2-week challenge idea. Anything we do, any antimicrobial dressings that we're using, we should at least try it for 2 weeks. Yes, the wound may start to see improvement, but don't stop your intervention quite yet. Continue with it for 2 weeks. Even if you're not seeing the results you want to see, you want to be more persistent to continue for a longer time to observe the outcome. And of course, at that time, after 2 weeks, then you come back to evaluate. Has the wound deteriorated? Has the wound improved the way that you want to see? And then go back into this cyclical nature of assessment, going through this process, the wound cycle process, to address the other problems that have perpetuated the chronicity of wounds. I think it's fascinating to read literature around biofilm, and I'm just trying to give you an impression of the technology that potentially could be available in the next 5 to 10 years. Looking at the use of probiotics, looking at other inhibitors that we can use to stop the crumb sensing. They use the term crumb quencher to address the ability for bacteria to send signal to each other, because biofilm is produced by a group of bacteria, not just by not just by a few bacteria. So the idea is to mute the bacteria so they cannot communicate with each other. So other therapies potentially can be used, like electrochemical therapies. There's a lot of interest in electrical stimulation, electrical therapy to break down biofilm, hyperbaric oxygen, light therapy, negative pressure wound therapy, and the pH modulation. So I think I'm sure that this area of practice is going to be quite exciting in the near future. So now, without a lot of the tools in front of us, a lot of times we have to rely on our clinical assessment, which I think is the most important element when we approach any type of chronic wound issues. And that's why no machines, no technology can replace our expertise and our way of thinking and evaluating wounds. So which of these wounds or wound is or are infected? Think about that. Is it A? Is it B? Is it C? And if they're infected, what do you think? What are the stages of infection? Do you think they're covert, biofilm-related infection? Is it overt, the deep infection? Or is it a spreading systemic infection that you see that is causing sepsis potentially? I know it's not that easy, right? And I'm sure there's a diversity of opinions out there. Sorry, I cannot see a chat box right now, but I'm sure there's some very some fireworks going to generate some ideas. And that's why we summarize all the key clinical signs and symptoms based on the literature review. And it seems like a very, very busy slide, but this is just really trying to be as comprehensive as possible to describe some of the key elements to separate biofilm-related infection that is usually described as a local infection because biofilm usually just established and adhere to the first few millimeters of the wound surface versus a deep covert infection that occurs when those bacteria entered into the deeper tissue, causing soft tissue infection, cellulitis, and other type of problems. So with overt infection that we see all the classical signs of infection, erythema, warmth, edema, pain, increased odor, versus more subtle signs associated with covert infection, such as granulation, the unhealthy granulation tissue, and odor and smell. And that's why, in my practice, I actually have summarized and condensed some of those signs and symptoms into a, hopefully, what you would consider a simple to use tool. And we have validated this tool in another study with Rosemary Hill in BC. And currently, we're actually evaluating this tool in Brazil. One of my students actually tried to validate the use of this tool with some of the microbiological analyses, fluid analyses, and also the fluorescence imaging. But anyway, you got me excited about talking signs and symptoms of infection. So what we see with local infection, we may include unhealthy tissue, pain, poor wound healing, X-ray, and smell, versus lower compartment infection. The wound would get bigger. There may be potential deep structural involvement, especially when bone is exposed, increase in warmth, edema, and erythema that goes more than 2 centimeters beyond the wound margin. So, and from my experience, for the diagnosis of local infection, definitely, I would say, venture to say 80 to 90% of time, there will be increase in exudation. As you can see, there's almost like this sort of greenish hue color of discharge from this wound, and wounds that dressing is soaked with wound fluid. And the other thing we often see associated with local infection with biofilm invasion is the unhealthy granulation tissue. And in fact, I have a very interesting conversation with Chris Murphy recently, and she's the past president for NSWOC in Ottawa area. And she introduces term granulitis. And I think there has something to say about recognizing inflamed tissue, unhealthy granulation tissue. And we decided we should work together to define this phenomenon in a better way. But as you can see, there are tissue here, they look pink, but they're not the healthy type of granulation tissue that we like to see in chronic wounds. For example, this wound, the granulation tissue is beefy red color, looks like, that's just too purple and not the pink moist color that we like to see. There may be friability, friable tissue. And a lot of times you may actually see the pocketing, the bridging of granulation tissue, suggesting some of those areas is actually more vulnerable to bacterial damage, more inflamed. And that's why you got this pockets of damaged tissue, pockets of a better zone, so to speak, with all those proteases produced by the bacteria and your body responds to the foreign material. And often with the wound bed, due to the presence of bacteria, you may see a layer of film. They're not biofilm, mind you, but they may have biofilm in them. But the films is almost like a gelatinous, slimy material left on the wound bed. Again, the analogy is after the battle and all the dead soldiers left on the field. And that's exactly what we see with the dead bacteria, with all the proteases and dead cells left behind and creating this kind of unhealthy looking granulation tissue. And just a reminder that clinical assessment is less than perfect. There are individuals, because of compromised immune system, people with diabetes, hypoperfusion may not be able to mount the inflammatory response that we like to see. And I think the clinical assessment would hopefully guide your further assessment and evaluation and also management of chronic wounds. That may include the decision whether you want to obtain a sample, a culture. And the purpose of the culturing is to determine if antibiotics are required. We know exactly what type of antibiotics to use. And of course, we all recognize that the Levine technique is probably the best approach and best practice for obtaining a sample to determine wound infection. Cleanse the wound, debride first, cleanse again, select small area, rotate the tip, and extract the wound fluid. So, how do we manage biofilm then locally? Just a reminder, vigorous cleansing, antimicrobials, and all the standard of care. And the idea with vigorous cleansing is to disturb the biofilm structure. That seems to be more confusion and more debate than consensus around wound cleansing. And I think just highlighting the area that we don't really have a lot of research in wound care, and we need further evidence to support. And I think what we actually recognize is by dribbling a few drops of water, saline, on top of the wound bed is not adequate cleansing of the wound. We might prefer soaking gauze with antiseptic and then dwell in the wound for at least 5 to 10 minutes. Just a reminder, scrubbing, swabbing could be potentially painful. And actually, a recent systematic review by Erin Mahaffey, she validated, looked at systematically a number of studies out there that swabbing may perhaps increase pain and also enhance the risk for infection problem. So just keep in mind that, and that's why there's a little bit of controversial about the proper technique for cleansing a wound. As you can see in this video, I was actually using a monofilament pad with the intent of doing an aggressive debridement, a mechanical debridement versus routine cleaning. And if you're doing irrigation, 4 to 15 psi pounds per square inch of pressure to irrigate, and potentially the use of surfactant as an ingredient to promote better debridement and cleansing as well. Surfactant, the amazing material, basically it's a hydrophilic and hydrophobic end, and the hydrophobic end is going to stuck to the biofilm structure, and then the hydrophilic head, they repel each other, and that's how they separate and destroy the biofilm structure and emulsify, almost like lifting them up, so they become like taking out the blocks of bricks from a wall. So when we're irrigating and cleansing a wound, keep in mind the amount of irrigants that we should be using. The best practice recommendation is about 50 to 100 ml per centimeter square of, depends on the wound length. The bigger the wound, the more irrigants that you're supposed to be using to properly cleanse the wound. And also a quick reminder that cleansing would involve the peri-wound skin, not just on the wound bed. Another area of confusion is around what the type of solutions that we should be used for wound cleansing, and pH does make a difference. We prefer a more acidic solution for cleansing the wound, because bacteria, they prefer to grow in more alkaline environment. In fact, they produce material that can alkalize wound bed. And that's why pH is a diagnostic tool to determine if there is a proliferation of bacteria. And just to illustrate the importance of pH, I think there's been a lot of discussion about hypochlorous acid. And it is actually, the pH level is slightly more acidic compared to the sodium hypochlorite, and they're not exactly the same type of solution. If the pH is being modulated to more alkaline, hypochlorous acid would turn into sodium hypochlorite because of the chemical reaction between the hypochlorite ion and also the chloride. So the end result is that it is less effective and is more corrosive with the alkalinity of the solution. And in fact, it can be very damaging to the wound tissue. That's why we don't really recommend the use of Dakin solution anymore, just because they are so corrosive, caustic. And the fact is the hypochlorite ion would not be able to kill bacteria as effective as the hypochlorous acid ingredient. So anyway, I thought that it's important to really settle some of the confusion and controversies out there. One area that I don't think there's a lot of debate about is the importance of doing regular debridement. Even with our NSWOC group, we have launched the document to describe what's considered as conservative debridement, when we're cleaning the wound with a blunt instrument and removing material, unhealthy tissue without causing bleeding. And you can see I'm using a Q-tip, using a forceps just to scrape off the material, and also now using a sharper instrument, using a cuvette, again, not to the level of any bleeding tissue, versus sharp debridement is when we're using a sharper instrument to cut into bleeding tissue and healthy tissue in order to promote better wound healing. But we all recognize the importance of conservative and sharp debridement. The more debridement is being done, the better the wound healing. It should be done 1 to 3 times per week, and in combination with other types of debridement method. What are the methods out there? I'm sure that we all can rhyme off a few differences, a few strategies here. Autolytic, mechanical, there are a variety of products out there now, including hydrosurgery, monofilament pads, irrigation tools, enzymatic agent. We'll come back to talk more about that, and biosurgical interventions. So enzymatic agents, I think, is probably one of the sort of undervalued, underused material in wound management. The only available enzymatic agents available to us in Canada is xanthal collagenase. If you look at the collagen, it's a trihelical structure. So it is like 3 strands of protein. They got sort of weaved together. And that's why collagen has such a high tensile strength, because the way that the arrangement, architecture of the collagen, healthy collagen. And if they're destroyed, if they're damaged, they become denatured. As you can see in this schematic diagram, the helical structure is altered from the denature process, and allowing that helical strand and the weave to be unraveled. So that's why they're weaker. And if you think about sloughy tissue, the denatured protein, that's why they have the stringy, sloughy, slimy consistency, versus a healthy tissue that has this high tensile strength collagen in them. So the magic is with the enzymatic agent, they can recognize the structure of denatured protein without harming the triple helix, the helical structure of good protein. So if you look at this video here, lots of slough on this wound with necrotic tissue. We want to clean up the wound bed. So enzymatic agents could be considered in addition to ongoing sharp debridement, conservative debridement. So applying the centicoagulase, we don't really need that much, about 2 mm thickness, and it's like spreading butter or peanut butter on a piece of bread. And the enzymatic agents would penetrate into the wound bed, get to the root of the damaged collagen, and find the root and cleave off the damaged, denatured protein. And that's how enzymatic agent works to promote better debridement and clean off the wound bed. So just to give you some idea, I got this gentleman with the wound, post-surgical wound on the knee, and apologize for the little blurry picture here, but you can appreciate that there's a lot of slough on this wound, and we try sharp debridement. And just because of the location and the pain that the patient was experiencing, we just couldn't do very aggressive debridement. So we thought, okay, let's try enzymatic agent. And after a few days, we can see that this area has changed quite significantly and continue to improve over time. And then by about 26 days after the application, you can see the wound is almost reduced by 92% in size, and you can see new epithelium around the wound, and the wound bed is pretty much healthy looking. So after you debridement, always think about the use of antimicrobial agents, because you want to make sure that you address the challenge, the potential risk for reforming, for biofilm from reforming. After debridement, after you cleanse the wound, after you disturb the biofilm, there's always those persister cells that develop tolerance to antimicrobials, that persistent cells that can survive over time. Yes, they may not be replicating as fast as bacteria that develop resistance. They're not resistant, they just have this tolerance to a lot of antimicrobial agents. So potentially, after 2 or 3 days, they can regrow and reestablish the biofilm structure. And it goes into this cycle of sort of perpetuating this regrowing and perpetuating this inflammatory response, as you can imagine. And that's why we need to think about, after disturbing the biofilm, utilize a validated, appropriate topical antimicrobial to stop the persistent cells from growing, to stop the biofilm from reforming. So as you can see, this is the variety of antimicrobial agents available to us with silver, iodine, PHMB, or polyhexanide, polyhexamethylene biguanide, chlorhexidine, Dakin solution, and honey, and also fatty acid dressing. So I think the good news is the most popular dressing between silver and iodine, they do have a very good platform to address and attack the bacteria from multiple angles. And that's why resistance is very, very rare to, again, silver and iodine type dressing. Yes, you can see that Dakin solution also have all those different mode of action. But remember, Dakin solutions are very, very, very toxic versus silver and iodine dressings. They're not cytotoxic. What about PHMB then? So yes, it's a long chain of molecule. They can actually, because of the charge on the molecule, positive attract the negative charges on the cell wall. That's how they destroy the bacteria. But a lot of dressings we see in Canada, they cannot release into the wound environment. They don't interact with the biofilm environment. So I'm sitting on the side that I don't think passive dressing, soaking the bacteria into the dressing itself, could address biofilm problem. So we need something that can directly work on the wound bed, go into the biofilm, or penetrating into the disturbed biofilm to kill bacteria. So based on the review of the literature and following this pathway from treating underlying etiology, looking at the different signs and symptoms associated with covert or overt infection, the local management of overt infection is to use a silver dressing. Looking at this individual with a pressure injury on the trochanteric area and lots of drainage, lots of redness and erythema and local swelling. So we identified that it's consistent with deeper compartment infection, and we actually apply the optical flags into the area. Of course, the material is ideal for pressure injury because of the softness, because of flexibility of material that is able to pack into some of the deep sinuses and undermining. And at the same time, with the silver, it's able to deliver a high concentration of ionized silver into the wound environment. As you can see, as the wound fluid interact with the crystalline silver, the cluster, the molecules deliver individual ionized molecule, silver, ionic ions, and then it will work very fast into and go into the cell, disturbing the cell wall structure and function, and eventually the bacteria is just going to burst from all the accumulation of waste products inside the bacteria. So yes, I think with the right treatment, the way that we recognize this is deep infection, we're able to improve wound healing. As you can see, this wound is so much better with the healthier granulation tissue growing into the wound. Okay, so what about covert infection? And again, following the signs and symptoms associated with biofilm-related infection, and we recommend the use of iodine-based product. In this case, in the pathway, we listed iodosorb, cadexomer iodine, as the selected agent. Why silver? Why not silver, right? So silver molecules, they're not very effective in terms of neutralizing the extracellular polymeric matrix in the wound, in the microbiofilm environment. And in fact, silver may take a very high concentration in order to destroy the biofilm structure. Versus with the cadexomer iodine, there are a few different ways that this type of agent is able to work against the bioburden and biofilm structure, in addition to promote better wound healing. First of all, the gel is able, and whether it's the ointment, the paste, and also the powder, is able to absorb and handle a high concentration or high volume of fluid. And based on some of the literature, you can see that this is a systematic review looking at 43 studies across the literature. And the only product that was reported to be effective against biofilm in terms of reducing the concentration and amount of biofilm is iodosorb, compared to silver, compared to PHMB and other agents in those 43 studies. And in fact, iodosorb is about 9 times more effective against Equicell AG plus in their conclusion. As you can see on the slide here, that there's a significant reduction following the use of cadexomer iodine gel. And we also conducted another systematic review just to validate that point that cadexomer iodine is more effective in terms of reducing pain, removing and defluffing the wound bed. Especially with some of the agents, for people not familiar, there's slight difference in terms of the ingredient, whether we're looking at the paste versus the ointment. And with ointment, there's also cadexomer, which is a surfactant material, which may be more effective to promote debridement and defluffing of the wound bed. But I think what we're interested is in terms of what the agent is able to deliver into the wound with 0.9% iodine to kill the bacteria and invade into the biofilm environment. So this is a video to show you the cadexomer iodine is more or less like a starch molecule, and it can absorb a lot of fluid into the individual cadexomer molecule. And as the molecule absorbs the fluid, it will release the iodine ingredient. The more liquid is being absorbed, the more iodine is being released into the surrounding wound environment, making it more effective to address a highly exudative wound. And similar to silver, it can bind to many different sites on the bacteria, so it can render the bacteria inactive and eventually kill the bacteria. So just to give you some idea, you can see this individual with the wound. She's obese. She got the trauma to lower leg with a big hematoma, evacuate everything. And after a few days, we noticed this inflammation, fibrogranulation tissue, and more odor. So we identified those signs are consistent with biofilm-related problem. We actually apply iodosyl powder on this wound because of the amount of exudation and the size of the wound as well, making the powder more easy to apply to different areas. And you can see that after 2 or 3 weeks, we're able to improve the quality of the tissue with less slough on the wound bed. For people not familiar with the powder, it's actually very simple to use, and we spread on the wound bed. And usually we prefer the wound bed to be slightly moist that will allow the powder to stay on the wound bed a little bit better. And in some of the cases, we apply the powder in very difficult to dress areas like between the toes, in the toe web spaces where there may be fungus problem. So yes, with the right duration, right treatment, 2-week challenge, and following the right treatment for the right type of infection problem. And then when we come back to do the evaluation, you can discontinue if there's no other signs of infection. And you can continue with the same antimicrobial dressing if you still have concerns about infection or the individual is still at risk for developing wound infection problem. Or we might want to change to another antimicrobial. And that's been my practice. After 3 to 4 weeks, if I don't see the outcome that I would like to see, I would switch to a different type of antimicrobial. And that's why we like this toolkit idea to recycle different types of antimicrobial ingredient, recognizing that some of those persistent cells may develop tolerance and develop some type of resistance to the antimicrobial ingredients. And then after that, you can think about other type of advanced therapy as we step up if the wounds are not healing according to the expected trajectory again. And in this case, we actually apply a negative pressure wound therapy, and you can see that the wound tissue is almost filling up the deficit, the gap. And I think she eventually achieved complete closure after a couple of months of other type of therapy. But anyway, I think hopefully I'm just a little bit over time, but hopefully we have time for some more questions. But I just want to summarize that by following best practice recommendations and evidence-informed practice, and hopefully this type of enabler would be able to enhance the practice and recognizing some of the signs and symptoms, differentiating local from spreading infection, and following protocol with the use of iodine-based product, particularly for biofilm-related infection. All right, so let's do a poll question, because I think Sub asked you earlier, are you confident? I cannot remember the results. I'm hoping that we have a different outcome by now. And Troy, help us to put this question up. So let's see.
Yeah, so after this session, how confident are you in knowing when to aggressively treat biofilm versus managing infection? So leave it open for a couple more seconds as we get at least half of our participants to weigh in here. And awesome. So I'll share those results with you, Kevin. Hopefully you can see that in front of you if you want to tell us what you see.
Oh, excellent. Fairly confident, about 68%, and completely confident, 12%. So I think we actually have achieved our goal tonight with people being more confident with the wound management. Excellent. Wow, I really enjoyed myself having this conversation with you this evening. I hope you actually have the opportunity to opportunity to review and reflect on your practice and some new tips for you.
Absolutely. And I can tell just by the number of questions we've got so far that everyone's very, I've been actively participating and very interested in the subjects here. So we do have some time for some questions. So Kevin, I might start with one of these topics here. We had a couple questions regarding negative pressure wound therapy here. Could I ask you, is it possible to use Santyl under negative pressure wound therapy? And if yes, are there potential benefits of this method, or what are those benefits potentially?
Excellent question. I don't think there's any contraindication to use center collagenase and the negative pressure wound therapy. Now, depends on the type of therapy you're using. So, for example, I show you on a slide the last couple of pictures using a Pico dressing, a single-use disposable type dressing, and it's like a piece of foam material. Using any type of cream, you're going to clog up the suction, the negative pressure mechanism. So I would not recommend that. And if you're using a gauze-based or foam-based, the larger pore sizes, potentially. So of course, the perfect answer is depends on the situation. That's always the easy way to answer any type of question. But no, joking aside, of course, you want to clean up the wound bed before you apply any negative pressure wound therapy. If you find it, okay, there's still a little bit of slough and very difficult to remove, I think a lot of times the negative pressure therapy itself should be able to clean up and suck away all those and lift up the necrotic and unhealthy tissue. But if you're talking about thick edge-cord tissue, well, I think you need someone to do shock debridement before you consider any type of negative pressure wound therapy.
Fantastic. Well, thank you for touching on this. I see one just piece of clarification in the chat. I know we talked about this in one of our past webinars. Can you remind us what the acronym is for TIME or TIME?
Oh, absolutely. It's either time or DIME. It's tissue debridement, infection management, moisture balance, and edge effect. So we have touched on tissue debridement, the different ways of debriding, infection management, how to recognize infection, and how to use silver for deep infection, iodosorb, cadexomer iodine-based product for biofilm-related infection, and the moisture balance. We didn't have a lot of conversation about that, but hopefully you recognize that there are different types of material out there. And then edge, think about advanced therapy, for example, negative pressure wound therapy.
Awesome. Well, thank you for touching on that. And if anyone is interested, we do have a couple webinars on that topic with Smith+Nephew as well on our NSWOC website. You're welcome to go check those out. Moving on to a couple other questions here. I know it was asked a little bit earlier on in the Q&A, and I know Carolyn already touched on it a little bit. Can you just comment on whether there's a substitute for enzymatic debridement?
Substitute for enzymatic agent? No, not in Canada.
Yeah, and the reason we brought it up specifically just to answer Laura, just in case anyone missed that there too, is for anyone who was worried about Santal being on back order, Carolyn was just mentioning that it's just momentarily. There aren't substitutes for enzymatic debridement, so just stay tuned and get in touch with your Smith+Nephew rep as well if you need to there. Another question we had is, are granulitis and hypergranulation considered the same thing since they both show signs of infection and wounds? Or what's the distinction between them?
Oh gosh, stay tuned, we're writing this up. So I think hypergranulation tissue is not exactly the same as granulitis. Hypergranulation tissue, and I think there are different types of hypergranulation tissue as well. It's basically supersaturated, superhydrated tissue. So it could be present in wounds that have a lot of fluid and basically soak up all the tissue, soak up all the fluid. Now, and of course, the reason why you have a lot of fluid potentially because of inflammation. But what we're trying to address is inflammation related to infection versus inflammation in relation to other reasons. So I think granulitis, I think also convey the idea of not just about the bulk of the tissue, but also the texture, the color, the consistency, and the quality of the tissue that constitute inflamed granulation.
Perfect. Okay, well, thank you for touching on that. It sounds like you got some work in the background to even expand more on that. So a couple other questions here. We're going to go over to some iodosorb questions here. One is about whether you would recommend using iodosorb with patients who have an iodine or shellfish allergy. Is that something you've run into before?
Okay, that's a wonderful question. If you ask our industry colleagues, they will say, sure, of course you need to be concerned because it's according to manufacturer recommendation and the regulatory requirement, we need to inform people of the risk. when you look at the literature, the risk is extremely low. They look at the different type of studies, different types of iodine, even for daily frequent use of high concentrations of iodine solutions, the prevalence of thyroid derailment and conditions, I think it's almost like 0.1% for a duration of time. So you can appreciate that the risk is quite low. Now, I'm not saying it would never happen. I actually come across one case in my career that individuals develop some kind of thyroid problem. So it depends on the frequency, depends on the vascularity, depends on the type of agents that you're using. And iodosorb, I think it's relatively safe. I think it's very safe because it's a slow release mechanism. Unlike, for example, over iodine solution, you're actually delivering a very high concentration, a lot of iodine molecules instantaneously into the wound environment. So I think the slow release mechanism and the ability to deliver the type of iodine is going to prevent a lot of the concerns that we have.
Perfect. Well, thank you for touching on that. And just to expand on one more question on iodosorb here, I know we're getting towards the end of the webinar. Do you know if it's common to have an increase in exudate after the use of iodosorb?
Is it common? I don't think it is necessarily a common issue. I've heard about people saying that, oh, iodine is pro-inflammatory. But I don't think it's always the case. In fact, there's some literature suggesting that iodine is anti-inflammatory as well. So it depends on how you define inflammation. If I have something that can kill the bacteria, I'm actually anti-inflammatory to kill the bacteria, to reduce and to address the cause of the inflammation. I think it is the ability for the cadexomer molecule to be absorbing and drawing the fluid into the molecule itself, give people the impression that the wound become more exudative. I think it's just part of that fluid management, fluid balance capacity for this type of sort of device to act on the wound to create a moist wound environment for wound healing.
Thank you. And sorry, I know I said only one more question on iodosorb here. We got a question on iodine powder here. Do you have any experience, or do you know what the impacts of using too much iodine powder? Does that contribute to patient discomfort, pain, or burning sensations?
I've never come across people complaining of burning sensation with the use of iodosorb powder. Yes, with put iodine solution, people do complain about burning sensation. As I mentioned, the difference between a slow release type of dressing versus a solution that has there's no backbone to or vehicle to maintain the sustained release mechanism. So you end up with high concentration of material being dumped in the wound environment. So that has not been my experience of increased pain, and in fact, the powder is biodegradable, and we don't really have to be too concerned about the too much powder in the wound environment. I think if there's a need, and of course, you don't want to be overuse the powder as well. Just like when you powdering, I don't think we recommend people to use top powder and baby powder anymore, but you use it sparingly, right? So in the places where you need them.
And can it be used in tight areas as well? I know that was one of the questions we got. It's okay to use in kind of complex or tight areas.
Absolutely, and that's why I sometimes prefer the use of powder, because those little granules can go into those area that we cannot get our fingers into them. Not that we're putting our fingers into anything, but because there are crevices, there are wound spaces, there are little pockets and bridges that we need to get the active molecule delivered into those environments where the bacteria and biofilm are actually in existence.
Fantastic. Well, I think I've taken up quite a bit of your time there, Kevin. I appreciate you coming and sticking on a little bit longer than our allotted time there. What I'll maybe do, because I know we have some questions that we haven't been able to get to today. I put in the chat there and subbed it as well. Definitely take a second to fill out that post-webinar feedback survey, and that's going to go to Smith+Nephew. I'm sure either by filling that out or getting in touch with your Smith+Nephew rep will be the best way to ask some more questions about what we were talking about today. And Kevin, I can't imagine this will be the last time we'll see you on an NSWOC webinar. So I hope we'll be able to have you on again in the future.
Thank you so much for joining me, and it's been a wonderful conversation. Thank you.
Thank you. And thank you again to Smith+Nephew. Again, this education could not have been possible without you. So for everyone else who's on the line here, I did put in the chat for some of those questions about how to join NSWOC or how to take one of our wound, ostomy, or continence courses or programs. You can go to our NSWOC, NSWOC.ca website or our WOCinstitute.ca website for those courses. We will be following up with an email to you with your certificate, so always get back to us that way if you have other questions. Otherwise, we look forward to seeing you at one of our next webinars. We only have a couple left before the end of the year, but we'll absolutely be coming back with quite a few more in 2024. Have a great night, everybody, and we'll see you next time.